So in terms of describing the pathway to recovery in thoracic surgical patients, it's a pretty broad discussion actually. What is a thoracic surgical patient is the question I'd ask. And we've got a very broad surgical specialty. Thankfully, it's one of the reasons that I enjoy doing thoracic surgery. And you could have something like this: a cervical mediastinoscopy through a neck incision, a small cervical incision about the size of a thumb. You could have endobronchial valves, which is a endobronchial lung volume reduction surgery, and you can have the big clamshell, thoracotomy. And it's a huge variation in terms of what the thoracic surgical patient is and how you manage them, etc. So a common pathway, I would say, is very much dependent on which patient you have in front of you. Generally speaking, though, day cases tend to go home, as with most day case definitions for surgery, including in other specialties, they go home within the same day. And this differs from the US definition or other country definitions. Our British definition is that they go home within the same day. We don't talk about 23-hour day, 23 hours, period, etc. We talk about the inpatient admission, day case admission, and then they go home that day. VATS or RATS, which is defined, which stands for either video-assisted thoracoscopic or robotic-assisted thoracoscopic surgery, anatomical resections or mediastinal resections. You're going to have to monitor drain output because these patients will have drains after their operation, and you consider removing them from day one, in fact, because the drain really just has two functions. It has an output, and it sits there sometimes to manage either air or fluid in general terms. Usually that's the only reason. If it's not doing anything, i.e. it's not draining any air or fluid, then it's just sitting there as a potential infection source, or and it should just come out. It doesn't need to stay, and it's not doing anything. So there's no periods where you have to keep it in for an extra day or day 2 or day 3. We don't have any strict definitions. Some people will talk about these things, but there's not really much of an evidence base for them. Chest wall resections, again, these are major operations where you're resecting the chest wall itself, including the ribs, the intercostal muscle, plus or minus the skin as well, and maybe with a reconstruction from the plastics team to fill the gap for a sarcoma or for invasion of something or a trauma to the chest wall. Very rarely you'd have to do it for a chest wall trauma. And that depends on the decision between the plastics teams and the other teams that are involved. We were involved with a case just the other day, actually, where we had 4 different teams. We had the diaphragm involved, but general surgeons came in, plastics were involved as well, and the liver was also involved with the malignancy. So the hepatobiliary team were involved. So there was about 4 different specialties, and clearly the patient has to be managed from all sides. And we may own the patient or look after them as lead consultants, but we have to discuss it with everybody to make sure that the patient goes home at the right time. Thoracotomy decortication, these are operations where you do essentially strip away the pleura that lines the lung and the chest wall, and so there's going to be a lot of trauma potentially on the lung itself, and the lung will definitely leak. You're looking at probably more than 2 or 3 days. These are fairly I'd say liberal estimates of inpatient stay. Usually people stay in longer than this, but we tend to discharge people as soon as we can. We have sent patients home with anatomical resections on day 1. We aim to do it day 1 or day 2, and we don't have any real ceilings or strict criteria in terms of duration of time when somebody has to stay in. We use the clinical parameters of the patient to help us to come to that decision. Pathway to recovery, again, that one of the considerations is the access for the patient, and is it all about the access? There's different accesses or incisions that you can do in thoracic surgery. The stenotomy could be a full midline, could be a mini. You can do a full thoracotomy, which could be posterolateral, anterolateral, an auxiliary thoracotomy, or even a clamshell like we saw in the image before. Immediate stenotomy is also possible, and you've got all these video-assisted or robotic-assisted thoracoscopic ports as well, which are again very minimal. That's more of a picture for that, for the VATS, and the robotic is fairly similar. And then you've got extrathoracic incision like the supraclavicular incision or a subxiphoid incision, for example, which are also relevant in thoracic surgery. So the incision certainly plays a role. I mean, a fat port is going to heal a lot quicker than a thoracotomy, and we know the evidence suggests that patients go home earlier because of benefits from potentially pain, as well as the transform mechanics improving more quickly with healing after a minimally invasive incision. And so that's certainly going to play a role in discharge and recovery. This is an important paper that was published now in 2019, which is a few years ago now, and it just really discussed some strong or hard points to sort of rally around for different thoracic units, mainly in the UK, but also across Europe. And they looked at 43, in fact, recommendations. We're not expecting you to learn all of these. This talk is pitched more for the SHO on the ward, but it's more, we're talking about post-operative recovery and post-operative complications. So an awareness of this is certainly useful and important, because we're all managing the patient, not just the consultants or the senior registrars. It's going to be a team effort. And if you know about things that should be happening that aren't happening, then you can either introduce them in your unit or aim to do them, at least with the consensus of the team, obviously. So these are 45 recommendations were discussed. The evidence level was scrutinized, as well as the recommendation grade from the team, the expert consensus team that came to the different conclusions. And they really looked at presentation to post-operative discharge and split the period from pre-operative to perioperative and then post-operative phases for all thoracic patients. And then general principles is probably what I would, going to be discussing and look at the consideration from an SHO perspective. You're going to have generally high-risk patients that you're going to need to optimize. You should always be aware of the tissue handling in the operation itself. And then there's perioperative considerations around the operation, and obviously the chest drain management. I mean, this is gross, summaries of these things, because there's a lot more to the patient after the operation than just the chest drain management. But I'm just going to focus on these things because they're probably more relevant to recovery and the different issues that SHOs may not be able to consider or appreciate in the thoracic surgical placement. So high-risk patients and optimization, let's talk about that. So really it starts before the patient comes to the table, way before, in fact, before they've even been admitted for the operation itself. And you're really looking at screening them for nutrition status and looking at weight loss and supplementing their nutrition to make sure that the weight loss is corrected. If you can, you counsel them and support them for smoking cessation, ideally 4 weeks before. And the reason for that is because the mucociliary mechanisms that are obliterated by smoking tend to recover, and then you get a lot of secretions. You want that to happen and then clear the secretions before you operate on the patient, rather than having the mucociliary escalator recovering and then you having the operation and then you're stuck with secretions and patients that are plugging off and requiring ventilation or bronchoscopies to suction them out and increasing the risk of infections. But in general, you always try to aim to promote smoking cessation whatever time that is before the operation. Alcohol dependence should be stopping the alcohol consumption 4 weeks before. Again, these are optimal ideals if we can. You correct the anemia of a patient that's anemic, and the definitions of that is beyond the discussions of this specifically, but they're well recognized within the anaesthetic community. And it's usually an anaesthetic clinic that's run to correct anemia. If there's iron deficiency, they correct the iron to try and recover the HB, etc. Pulmonary rehabilitation is particularly helpful, and it's the mainstay of one of the important steps, actually, rather in lung volume reduction surgery, but it should be applied in patients for anatomical lung resections as well, particularly if they've got borderline pulmonary function tests or their exercise capacity is slightly reduced. And this involves a program where you exercise the patients, you teach them breathing exercises, physiotherapy, etc. This is all before the operation, obviously, in the outpatient setting, and you try to really optimize their ability to move and breathe in an effective way to help them cope with the pain as well as the insult of the resection of the lung that you've done after the operation. So we'll move to tissue handling. And again, there's just general principles here. Where you're in theatre as an SHO, you should get stuck in, and you'll be closing skin. Most people start with skin, and I think that's a really, really useful way of gauging your tissue handling and your techniques of your surgical technique, rather. And if you're doing an anastomosis, i.e. a bronchial sleeve or a vascular sleeve. Again, these are very advanced, but you always aim, a general principle is that you aim for attention-free anastomosis. And that means that you mobilize the lung, you divide in the adhesions, you try and bring the edges of the anastomosis that you're doing as close as possible to make sure that it's not under tension, it's not being pulled away, which means that the blood supply is potentially compromised or reduced, and therefore healing is impaired. Again, that principle can be applied when you're doing what we said before, the skin. If you're closing skin, you should approximate. The principle is that you approximate the edges, you don't strangulate. And strangulation is when you really tighten the edges, or you tighten the suture onto the skin itself, and you can actually see that the blood supply is compromised because it goes pale, it blanches. And you look at this red wound, and it's got blanching where the stitches are, and you know that's probably a little bit too tight. Remember, you're going to have some edema, so you probably want to slightly under approximate rather than over approximate things, because the edema will also pull on the tissues and may impair healing. So it's a bit of a fine balance. Obliterate spaces and protect with drains. Again, that's a really important principle. So if you've got space, for example, after the lung resection, you've got a space, you'll have a space where the lung was, and you're going to protect that space with putting drains. Spaces in the soft tissues, for example, when you're doing a chest wall resection, or when you're doing a muscle sparing thoracotomy, or even a normal standard thoracotomy, muscle splitting one, then you're going to try and make sure that the muscle layers are sitting right next to each other. You're closing them close together. I wouldn't approximate layers of muscle to get to each other, because that you can get tethering of the movement from the shoulder, etc. When you're closing a thoracotomy, for example, that'll be the classic example for this. So try to close each layer together, the muscles, bring them together. But again, you try to obliterate any spaces to make sure that you don't have any cavities. And if there is any that you're worried about, or you think, oh, that could be a source of or a potential space that seroma can form, for example, inside the soft tissues, then you put a small drain in to protect that space. Perioperative considerations. So, in perioperative considerations, there's lots. I've just focused on a couple, mainly from that paper, actually. So VTE prophylaxis, again, really important. You want to make sure that patients or cancer patients particularly don't get any pulmonary thromboembolism. And so VTE prophylaxis is done at the time of the operation. You put the TEDs on, you put the pneumatic compression stockings on, as well as giving them VTE prophylaxis, chemical VTE prophylaxis on the day of the operation itself, unless obviously they're bleeding or you're concerned about bleeding, but rarely that's the case, and we tend to overdo it rather than underdo it, because these patients are high risk for developing PEs. Hypothermia prevention, again, it's a really important principle, making patients normothermic. You use a bear hug, or you warm the patient for quick operations. If you're doing a washout, pleural fusion, talc pleurodesis, these very simple pleural biopsies, these very simple operations, you probably don't really need to worry about it. Your more mainly concern for hypothermia prevention is when you're staying on the table, or the patient's staying on the table for an hour or more. And that's when you bring the bear hugger out, you use the Inditherm mattress if you've got that, etc., to make sure that that's corrected. Lung protective ventilation is mainly for the anaesthetist. I don't think you need to worry about that as a surgical SHO, and that's essentially what you do when you change the settings on the ventilator to on one lung ventilation, where you're trying to ventilate the patient just on one lung while you've got the lung collapsed, and that's done by making sure that the pressures are not too high, and then you're not causing any pneumatic damage or barotrauma to the lung itself. Regional anesthesia use is very important. It's always debated which anesthetics we're going to use to block, what sort of blocks you're going to do. Are you going to do it external? Are you going to do it from the inside? Is there anything that's going to do it? Are you going to leave a catheter in? These are all questions that are always asked and discussed, and people have different views on them. I think that you should always try and put local anesthetic in the area and aim for an intercostal block. I find them very effective. Sometimes a catheter is helpful because you're expecting the drain to stay in, or that you've done a thoracotomy, for example, or you're expecting pain to be a particular problem. And that's also related to the patient conversation that you have. Have they had any problems with pain before, etc.? It can be quite detailed. And any of these, to be honest, any of these topics can be a lecture or presentation in themselves. So we really are summarizing things as much as possible. But regional anesthesia use is definitely a recommended thing to do, in addition to obviously the general anesthetic that they're going to be getting if you're doing standard thoracic surgery. Awake thoracic surgery is also coming into the fore, but it's not generalized at the moment in the UK. Magnesium supplementation is discussed as part of atrial fibrillation prevention. Atrial fibrillation is a common arrhythmia you can get in cardiothoracic surgery. It happens in thoracic surgery as well as cardiac. It's not as much known about in thoracic surgery, but it's certainly a significant complication that happens. And it happens mainly with anatomical resections, mainly with the bigger resections, i.e. pneumonectomies. But lobectomies also have a significant one. Segmentectomies have a lesser one, and wedge resections, for example, have probably the least associated with atrial fibrillation post-operative. If the patient's on beta blockers, staying on them will help to prevent atrial fibrillation. So that's recommended to have. And then if you can try and if you have to do a thoracotomy, we talked about minimally invasive surgery, and we always try to aim to do that because the benefits are quite clear when you see the difference. And there's been a randomized controlled trial now that demonstrates the benefits of having a minimally invasive operation. If you're going to be doing a thoracotomy, though, then trying to avoid muscle splitting and using muscle sparing thoracotomy techniques is probably better. Although I'm not aware of a randomized controlled trial specifically looking at that, but the principle is that you're preserving the muscle, particularly in younger patients where you don't want to be cutting through the muscle that can impair it, cause atrophy to the muscle, and then they have a weakened area. And I remember using it, for example, in patients that are using wheelchairs or young patients that are particularly active in manual work, then a muscle sparing thoracotomy can be useful. But we do sometimes get an increased rate of seroma with these patients. Intercostal muscle sparing, intercostal muscle and nerve sparing techniques, again, you should try and use those. And that essentially means that you mobilize the intercostal muscle so that when you're closing putting the retractor in to open the thoracotomy, you're not actually pinching the intercostal muscle itself and particularly pinching the nerve, crushing the nerve, potentially making it out of action or cause atrophy of that intercostal muscle and damage and also neuropathic pain. Chest drain management, we'll talk about in a little bit. So chest drain, as an SHO, I think we could probably best to talk about chest drains in general. So you've got these surgical chest drains. Sorry, can you see the pointer, Rob? Can you see the pointer? Hello? Can somebody just confirm if you can see the pointer or not?
Yes, we can see the pointer. Yeah,
you can see it. Perfect. Sorry, I thought I was getting very lonely down here. So thanks for saying something, Hanad. So the chest drain you can see is this standard chest drain is a 4-chest drain here. This particular model is a 28 French, and it has a trocar as well. You've got different versions of drains that you use. We tend to use these surgical drains in our operations, and we don't have a trocar because we're not using it to guide it into a specific area. We can see it with the camera usually when we're doing thoracic surgery. When you look at the drain itself, it's connected to a bottle. It has its tubing. The tubing goes into the drain, and then the drain tubing goes into the bottle itself. And the bottle's got obviously measurements on the side. And the reason I'm going through this may be very obvious to you guys, maybe very common. You're thinking, what's he talking about, chest drain? I'm just sort of pitching it at a general SHO level where you may not be aware of these things. So we'll just quickly whittle through it, not going to be dwelling too much on it. The other thing to be aware of is the digital drain. And in our hospital, we use the Medela Topaz digital drain, and it has this nice little screen which tells you how much air leak there is. It quantifies it, as well as the drainage as well, which is split into the last hour as well as the total since it's been put in. So it's a really, really helpful information, really useful. So going back to chest drain management, the recommendations for enhanced recovery in thoracic surgery is that you avoid routine suction on the drain. And there's again an endless debate similar to the regional anaesthetic discussion, about what sort of suction you should put the patient on, how long you should put it on for, etc., etc. Generally speaking, you try to avoid it because suction is thought to potentially cause some trauma to the pleura and the lung parenchyma, i.e. the visceral pleura, as well as causing stretch and potentially injury to the lung itself. And the more you minimize that, the better, really. So if you can avoid putting any suction on, then great. You should try to follow that. And digital drains help you to using digital drains again is another recommendation, and they help you to see what sort of air leak you have, And sometimes when you can actually see that when you put early con, when you put the suction on, the early increases. The people that use suction tend to use it to try and suck the lung into the space and minimize and obliterate the space, because spaces tend to be the enemy of thoracic surgeons. Because when you have a space, then there's always a potential that it will fill with fluid, and that fluid can potentially get infected. And if you've got the fluid around stenosis, for example, after a pneumonectomy or something like that, then that can be a real problem and cause a bronchopleural fistula, which we'll cover very briefly later on in the presentation. So when you remove the drain, the recommendation again is to remove the drain as soon as possible, and that means even if it's making 450 mils, we actually go up to 500 mils in our unit. If the patient's made 500 mils in 24 hours, then we still take the drain out anyway, because and obviously that's with the caveat that they haven't dumped in the drain 500 mils in the last hour, because that would be, particularly red blood would be a cause for concern. And again, that's the consideration there is what's coming out of the drain. Is it just serous fluid, which, maybe a reason to keep it in if you've done something like a pleurodesis, TAP pleurodesis, and you're still draining a heck of a lot of fluid in 24 hours, then you may want to keep it in for a bit longer on suction to try and get as much fluid as possible, to try and get that lung right up to the chest wall to obliterate it. Use a single drain rather than two intercostal drains, and the reason for that is we tend to modify our drains. So we put the drain apically, and then we have a little hole about 10 centimeters or a couple of centimeters away from the chest wall. We measure that, and that will drain the basal space. So you can actually do the function or have the function of two drains with just one. That may be off-label use of the chest drain, and modifying it, potentially can open yourself up to litigation issues, but we tend to do it fairly successfully in our unit, and it avoids a patient having two drains. Now, what happens if you have two drains? The benefits of having two drains is potentially that you can have better drainage, so you get all the blood out, you get all the air out, but with the compromise of obviously that the patient has two tubes sticking out of their chest, which is painful, and they're also hanging around and carrying around two chest drain bottles, which again is problematic for mobilization. So single rather than two chest drains when you can. And usually that's the majority of my cases. I don't tend to put any second drains in unless I'm worried about an empyema, and even then it's debatable whether that's the right thing to do. But if I'm worried about drainage, then I may put two, and very, very rarely three drains even, in fact, in something like a pleurectomy, pneumonectomy, pleurectomy decortication type scenario. You try not to use urinary catheters as much as possible. Even when patients are high risk, you try to sort of find ways of optimizing them so that you can avoid using the urinary catheter, because it's another tube sticking out of the patient that can get potentially infected or slow them down mobilizing. So you try to avoid that to get them out of the hospital quicker. You mobilize them within 24 hours of surgery, and actually we're promoting mobilization as soon as they hit the ward. So they come out of theatre. We're not like the cardiac surgeons, for example, where there's a bit of the patient stays asleep. You wake the patient up. The patient goes to recovery. They're monitored for any significant hemorrhage or instability. Then they go to the ward, and the ward, the recovery starts as soon as they hit the ward. In fact, potentially you could, there are some centres in Europe where they walk the patient from recovery to the ward, and that's the really kind of sort of should hit home with how quick patients should be trying to mobilize and getting themselves moving and reducing the risk of chest infections, etc. Mini track usage. This refers to the mini tracheostomy device, which is a sort of device that is not as used as much as it used to be, and it can be a dangerous device if used in the wrong way or in the wrong circumstances. And the recommendations is that you put a mini trachea in theatre under vision, in a very controlled manner rather than in a rush scenario. You should never try to shove one in, and patients have died from that sort of behaviour in the past. And you use them really to suction, not really to ventilate. And it also is a very clear sign to the ward staff and to anybody that sees the patient that this patient is high risk. And when we say high risk, it's somebody that smokes, somebody that has COPD, bad COPD, bad lung function tests, and has steroid use. There's all sorts of different reasons for somebody to be high risk for secretions and compromise and chest infection. And this allows you to suction them. And really what it does is actually just irritates the back of the throat and then gets them to cough, rather than any specific suctioning. But we do use it in certain circumstances. we talked about that. So I just wanted to highlight, for again, the people that are not maybe familiar with the different chest drain sort of changes or parameters that you may expect. So this picture is supposed to highlight to you an air leak, and an air leak is where air is draining from the pleural cavity, and what you get is a bubbling effect on the water that you've got in the drain. Obviously, the drain, or may not be obviously, is filled up to this prime level, and that's 0, and that's filled up with just water, clear water that just fills it up to allow it to have the underwater seal, because this is the tube that goes in under the water, so that allows any air to come out, but not to come back in, because it has to go through the water, so there has to be some pressure for it to be pushed back in, and that's not usually possible. So that's how the drain works, really. In this picture, it's supposed to highlight, just typical hemoserous drainage post-operatively, potentially. And this one is just, you can notice that the redness of the fluid is a lot darker. It's more opaque. So in this one, you can almost see through it. You can see the back of the, the handle of the bed just barely through here, and you can see the end of the chest tube drain, the chest tube tubing, the chest drain tubing through it as well. In this one, it's fairly opaque. You can't see much of it, and this again would signify more blood, component rather than some hemoserous, so i.e. some pleural effusion mixed with a bit of blood from the operative field. You'd be more concerned about this because clearly there's going to be more blood component. Again, it's difficult to highlight it in the presentation, but you'd look for the color of it, and if it's bright red, for example, then there's active arterial bleeding. If it's darker, then it may be from a venous side. But the color of the blood is a bit more subtle, and it comes with experience. And even, to be honest, the type of fluid that comes out is a bit more subtle and comes with experience anyway. Recognize common post-operative complications. So I think we've talked about the pathway to recovery in thoracic surgical patients, and the different types of things to consider in the pathway to recovery, as it were, in a sort of broad sort of manner, and looking at a number of different things. Again, we can't be exhaustive or too detailed because we don't have time in this presentation. But we'll talk about recognizing common post-operative complications now. And how common these are depends on your unit, but we can talk about the commonality of it. I'm not going to dwell too much on a cardiothorax or laryngeal dysfunction for you guys, because I don't think as an SHO is necessarily something that you're going to be particularly focused on. But we'll briefly mention them as well. I mean, pain obviously is a very important thing that happens after any operation, and that's comes from the incision itself. And there's different types of pain, and it may become chronic, and what the definition is of chronic pain is debatable. Generally speaking, some studies have talked about chronic pain being at 6 months down the line. Some people use the definition of pain associated with the incision in the outpatient setting, which is usually 6 weeks, and some people use different figures, and it's arbitrary to a certain extent about what chronic pain is. But certainly, if you're having pain after 6 months or at 6 months, then that's definitely chronic. It can be neuropathic. And neuropathic, essentially, the definition of neuropathic pain we'd put down as being pain associated. So you've got abnormal sensations associated with the area of the incision that's related to normal triggers. So, for example, rubbing the area, rubbing your hand. When you rub your hand, for example, you're not going to get any pain normally. You wouldn't expect to get any pain. But if that's causing you pain, then that definition would be called allodynia, and that's just an abnormal hypersensitivity, as it were, to the pain. But if you've got abnormal sensation, i.e. a tingling, or usually they say burning sensation, then that's more suggestive of a neuropathic component. And that really just means that the nerve has been affected and tends to require different pain management to the acute normal pain that you get through the nociceptor pathway that we've got a diagram of on the presentation slide. Okay, what investigations? Because we have to talk about investigations associated with these. Well, I think with pain, it's difficult to investigate it beyond pain scores. And usually the classic one when you take a history, when you as a medical student, still applies. Score from 1 to 10, 10 being the worst pain you've ever had in your life. It can be a rough, crude way of doing it. There are other more, I'd say, more objective ways of scoring it depending on the unit. They'll use a pain score. And if you want to be really detailed, you can use a pain questionnaire. And there's lots available, but they're usually limited or restricted to the research setting. Air leak. So air leak's it's a really interesting topic actually, where you've got air leaking from the lung, and you get this bubbling in the chest drain that we described or looked at earlier, and it will happen normally sometimes after an operation because you've just stapled the lung, and there's going to be a bit of gaps or a bit of damage to the lung where you've stapled it. But the handling of the lung as well is really, really important. And we're appreciating this more and more, being very gentle with the tissues. Not, even when you mobilize the lung, you're just very, very gentle, and you do it carefully without much tension. You mobilize it, then you increase the tension, etc., rather than just shoving it around and pulling it and prodding it, because that just damages the parenchyma, and then you get air leak. And the reasons that you want to avoid air leak is because it keeps the patient in. Once you've got an air leak, you can't take the drain out, and if the drain comes out, you'll just tension, because the air will accumulate, leaking from the lung itself, pushing the lung down and causing a tension effect potentially that shifts the mediastinum, and then you get into a almost like a cardiac tamponade scenario. Generally, you'd call a air leak prolonged when it's been present for more than 2 or equal to 4 days. Why is it that? Because it's an arbitrary figure again. Some people define it differently. We'll stick to 4 days, and some people, because we're getting patients out early, as I said, anatomical resection, we're sending them home on day 1. Then it becomes a bit of a difficult definition to adhere to, because sometimes you'll send them home before that. So if you're in routine practice, some will have changed that definition to, if your routine practice is that you send them home on day 1 or day 2, then if you don't send them on day 2, then that's prolonged air leak, not just waiting to day 4, which is in this day and age, after a vascular lobectomy, for example, probably on the long side of inpatient hospital stay. It's affected by tissue handling. We talked about prodding and poking the lung and being respectful of the tissues, as well as your stapling technique. So when we talk about stapling technique, your stapling, usually the fissure is the most problematic. The bronchial stump, we'll talk about that in a while. But the principle when you're trying to staple the lung is that you compress the tissues, or you try to define where you're going to be going with the stapler to make your fissure, and then you slowly take small bites. You're not going to. It's rare that you've got a very complete fissure, or it depends on the patient population. Actually, there are some populations that have very good fissures all the time, but rarely in the British population do you have a very good fissure all the time. And so you take more than 1 or 2, 3, more than one staple, and you're going to have more than one staple line. So you align the staple line to slightly overlap, but be on the same exact alignment as the previous staple line. And the reason that you do that is because if you get crossing of the staple lines, then that can be a problem for the staple to be applied properly, and therefore more likely to leak air, and that could be a source of your air leak. The other reasons that you do that, so the other things that you can consider when you staple, i.e. under stapling technique, is that you could buttress your staple line, or use reinforced staples using like a felt type material, or using even pericardium. You could take a bit of pericardium and use that to staple, just to buttress, or even Teflon. But Teflon tends to be a bit thick to buttress the staple line and give it a bit more reinforcement when you think that the lung quality is very poor, i.e. highly emphysematous patients on lots of steroids, where the parenchyma is very thin and is more prone to tearing even when you've stapled carefully. Patient factors, we alluded to that slightly just now with regards to emphysema, immunosuppression, steroids, diabetics, these kind of patients. You need to be careful with them, and they will be more likely to have air leak. I haven't included in the slide, probably on purpose, the different seals, or really there's only a few seals that you could try to use to treat air leak, because I don't think that they've been demonstrably effective, in a big enough trial, and there's some potential issues with using them as well. So we could talk about the usage of air seal, sealants rather, for air leak in a different discussion if you want. It's usually a waiting game. I say that because air leak will stop eventually, You just have to wait. So they keep the drain in, and you can keep the drain in for weeks and weeks if you really need to, and it will eventually stop. The lung heals. You get potentially granulation tissue or scarring that will close the source of the air leak, and that's usually enough to settle it down. But if you're want to get the patients out, and usually patients don't enjoy being in hospital, they're delayed, they're disrupted from their life, they can't see their loved ones. So you want to get them home, and it's a shame really, because patients could be otherwise very well, but they've just got air leaking from the lung, and you can't take the drain out. So you could attach it to a flutter bag or an equivalent, which is something like a Heimlich valve, or even a rocket bag potentially can be used for that. Although a rocket bag tends to be more for increased drainage, and that allows you to get the patient out of hospital. So they've got the drain in, but they go home, but you have to have the right support mechanisms in your team to follow these patients up, to see them again as ward attenders, to make sure that you deal with any issues that they have. Patients can be walking around and then suddenly by accident unhinge the drain, and then you're in a scenario where you may have entrenched air into that drain, and so they need to come back in for an X-ray and reattach the drain, etc. You rarely have to re-explore air leak, and I think that stands generally for modern thoracic surgery. We don't tend to have to re-explore air leaks the vast majority of cases. You're more likely to re-explore if the lung isn't fully up. So you've got an air leak when you look at the drain or when you look at the topaz, but the lung, when you do an X-ray, is fully up. If it's not fully up and is down, then you're more likely to need to re-explore it because it's potentially causing compromise. And then if there's obviously the patient compromise, then that's a reason to re-explore the patient. Or if it's affecting ventilation, i.e. they're intubated and they've got such a massive shift of air into the pleural space that they're not even being able to ventilate the other lung or the rest of their lung, then that's another scenario where you need to deal with the air leak surgically. And then bronchopleural fistula could be a cause, and that's going to be more likely to be a need to be re-explored. And we'll talk about that now. So bronchopleural fistula, or a BPF as we abbreviated it in the previous slide, is a tract between the central airways and the pleural space. And when we say central, up to the segmental bronchi, I would say, is my definition of central. And then that's communicating with the pleural space and clearly causing an air leak. It's particularly concerning after a pneumonectomy, but it can happen in other circumstances as well, especially if the pneumonectomy is right-sided, then you're more likely to have a bronchopleural fistula. And the reason for that is anatomical, because of the blood supply to the right lung, or the right main bronchus even, in terms of it having just one bronchial artery rather than two on the left. It can be early or late, and the definition for that, again, there's different definitions, but we'll stick to a definition of less than 14 days for post-operative for early, and late being more than 14 days. And the reason we differentiate them is because they tend to have different etiologies, i.e. different causes, and that's why it's useful to differentiate them in that sort of way, so that you can consider what you're going to deal with, how you're going to deal with them when they arise. Early is particularly if you see it after 4 days, is related to mechanical failure. And we're talking about not suturing the bronchus, the bronchial anastomosis correctly, a stapling malfunction, that's led to air leak, or using the wrong stapler for doing for stapling the bronchus or the lung, but usually the bronchus we're talking about with bronchopleural fistula, and that's all, those sorts of mechanical failures. Late is more likely related to infections or malignancy recurrence, or in the actual stump itself. There's a reason for the stump to be ischemic or infected for whatever reason, and then if you've resected a central tumor, there could be some malignancy from the node itself that's around the bronchus, or from the tumor directly invading into that bronchus, and therefore you can get recurrence. And if you're within 14 days, you may not have the pathology. So clearly, the pathology is going to be useful to help you to differentiate whether you've done an R1 or an R0 or an R1 resection, which tells you if i.e. the cancer is right at the edge of your resection margin, or whether you've actually taken a clear margin without any cancer in it, which is what you aim for when you do these cancer operations. So how do you manage a BPF? Because we have to talk about management, and it really falls back to the same principles that you use whenever you're answering any question about management of a patient. You go back to the ABCD, and we don't just talk about the alphabet. We talk about really considering any airway issues. And the problem here is that there is an airway issue because potentially the patient may not be able to ventilate, or sorry, not airway specifically, but breathing, may not be able to ventilate unless you've got obviously a tracheal injury, which is a different sort of pathology. Then you need to manage it obviously directly, and it may require you to go back to theatre to do that. It may require you to intubate the patient. It may require you to do all sorts of things. So usually these patients are given to you, or you see them after they've come through the emergency referral, the pathway, and they've already seen a senior doctor who's accepted them. They don't tend to be that unstable that you have to, start thinking about how to manage them there and then, unless they're post-operative on the ward, and then something very badly has gone wrong. And I've seen that happen in one patient that I remember quite vividly, where the patient had their operation. The next day, they were struggling to breathe. Chest X-ray showed the lung was down, big air leak, and they had to go back to theatre. And they had a tracheal injury, carinal injury rather, when the surgeon had taken away or dissected around the station 7 lymph node. In a pneumonectomy patient, again, we're generalizing BPF to all sorts of scenarios, but generally we tend to see them in pneumonectomies, or we'll see them in a pneumonectomy patient. Your main principle after you've stabilized the patient, or the patient is relatively stable, is to protect the residual lung. And you want to do this by turning the patient away, onto the side away from the side of the normal lung, so towards the surgical side. So say that you've got a right pneumonectomy, you're going to lie the patient onto the right side because you want to keep the remaining lung away from any fluid that's going to go through the BPF. You put a chest drain in, and you put the chest drain in to drain the fluid around the stump, which could be causing infection, and it could also be leaking into the airways, which again is going to go into the other side, which is your only lung left. And if you get a pneumonitis or a chest infection in the remaining lung, then the patient just dies, and that's a real high mortality scenario where you're going to be in real trouble. And that's why we do this. So when you nurse them on the side of the operation itself, you protect another lung, and then you're going to be. It gives you some time to think. You give them antibiotics as well because you want to make sure that any infection is treated, and because of the likelihood of infection potentially being there. And again, we're talking about mainly late BPFs. But if you've got evidence of infection, or you suspect that there is, infection, you'll have a low threshold to start antibiotics in this sort of scenario. Then you have to think about how you're going to sort this out. And if it's early, then you're going to consider taking them back to re-explore them. And then you've got enough time, because if infection hasn't usually settled in, it's just a mechanical failure. Well, I say just, it's still a problem, but it's a mechanical failure. So you need to correct that by buttressing the suture line, resecting away the stump that's failed, making it more central, considering, or you should always potentially in this scenario, I think you should always cover the stump with a vascular flap, because that also protects the area from having any infections, and that's how you would deal with it. In a late one, you're going to give yourself time. These patients, particularly very late ones, if you're talking about a year down the line or 2 years down the line, and it can happen, then you want to really optimize these patients, because they tend to be very cachectic, very wasted, very high-risk patients. If you take them to theatre, they're likely to die unless you optimize them. So it's a balance between sorting out the BPF, and usually the BPF is actually very well tolerated. So the actual shift of air is well tolerated, and it's more the bigger picture of the patient, i.e. the lack of nutrition, the steroids, the infection that's going on that's causing them to be cachectic and wasted, is going to impair their healing, is what the problem is. And they may not even have enough muscle to be able to cover the flap if you're going to be using a muscle flap. So you have to really think about how you're going to manage these patients, and you should discuss them in your high-risk MDT or with your colleagues when you're managing them. Again, not something you're going to be doing really as an SHO. I think you'll just be doing the ABCD, making sure that there is somebody that's short of breath. You do a chest X-ray. You look for any air leak on the drain itself, i.e. there's bubbling. and you're going to see a big air leak if there's a BPF. You're going to see it, potentially the bottle rocking around, or the patient's ventilation is compromised. They're not being able to fill their lungs if they're on a ventilator. Bronchoscopy is used to really diagnose the BPF, and what you'll see is a little hole at the end of the stump. And potentially, if it's big enough, you can look through it and see the pleural space. You don't tend to see it that bad, but sometimes you can. If it's very, very small, i.e. less than 0.5 millimeters, then you can try and do conservative measures by just diatherming or using cautery sticks rather to the end to promote granulation, so that it slowly seals, the hole slowly seals. And we're talking, remember, about these patients in the chronic scenario, or the late phase rather, where they're well tolerated and they're just coming from an outpatient sort of setting, and you can manage it like that. Or you can even use endobronchial bioglue endobronchially, but you have to be very careful and be clear that everything else has been sorted out. There's no recurrence of malignancy, etc., before you start wading in and treating it like that. CTs are useful because they can give you an idea of the location of the bronchial pleural fistula, as well as if there's any associated lymphomas, infections, any other areas or collections that could be a potential source or reason to suspect infection. But you'd want to do that before you take the patient to theatre to sort of manage, and plan the operation, rather than, as the first port of call. VATS exploration, we talked about it. VATS exploration to look at the area where, the stump, etc., or even having to do an open thoracotomy, either through the same room that you've done before, if you did it open, or if you did it minimally invasively, then through those, then through another thoracotomy. But you tend to do pneumonectomies because of the size of the lung that you're moving through an open approach. Post-operative complications, bleeding. We'll talk about a little bit about that, and you can talk about the different definitions of blood loss, according to times, the time the patient's been out of theatre. I think that it's the rate of the bleeding that's useful. Okay, when you talk about rate, you want to talk about the amount, or you want to consider the amount and the speed of bleed that's present, and whether the patient's hemodynamically unstable or not. And again, the same principles of ABCD still apply in terms of how you assess the patient and consider the bleeding. So I think one of the first things that I do when I look at a patient post-operatively, if I'm worried, or even if I've been asked to assess them, is to look at the drain, because the drain tells you a lot of information. And we talked about, again, the different colors of different drainage elements, and how worried you are about them. Sometimes you want to you'll base the decision on the color of the risk for the patient that you have in front of you, rather than just the amounts and the rate of the bleeding that you're seeing. I think that one of the useful things to consider, and I know this is trauma related, is how much hemorrhage you've lost. And remember, when you've got a tachycardia with no significant change in blood pressure, you can lose up to 15% of your blood volume. And then you've got progressive changes in your hemodynamics and physiology according to how much more you've lost. And I think that's a good way of gauging things. And sometimes patients will be tachycardic because of pain, etc. But it's something in the back of the mind to consider and be aware of. And certainly, if there's any hypotension in a patient post-operatively, immediately post-operatively, then you need to worry about either the block being in the wrong place if you've left the catheter, or significant bleeding. So check the drainage. Ask the nurses, have they changed the bottle recently? If they have, then how much is the total drainage? Because sometimes it's not documented as well as it should be on the wards. So it's really, really important to gauge that. So when you assess the drain, see what's coming out, how much is coming out, okay, how long it's come out for. So in the last hour, it's good to, when you're talking about to somebody about this, to say, in the last 15 minutes, I've had this much. In the last hour, I've had this much. In the last 2 hours, since they've been in our theatre, I've had this much. And that really quantifies and gives you somebody at the end of the phone a good picture of what's happening to the patient in front of you, and then allows them to make a decision. Again, as an SHO, I wouldn't expect you or think that you should be worried about when to take the patient yourself to theatre, because you're going to have to get somebody in at that point. But to gauge how much the patient's got significant bleeding is certainly something that you should be doing and escalating accordingly. Anemia is an important consideration. and that's looked at clinically and on post-operative bloods. Usually we don't do the bloods on day 0, i.e. as soon as the patients come out, but the next day we tend to have bloods for anatomical resections. We don't tend to do bloods for other patients, minor cases, for example. But again, different patients. For example, in a patient that's high risk of bleeding because of a coagulopathy, then you may need to do it sooner, or you may request bloods. But as a general rule, you don't. And I can't recall a patient that we've had to take back to theatre. I've had to take back to theatre that hasn't had a clinical evidence of anemia, that's been pale as a sheet, that looks really unwell. And sometimes, in fact, they look like that, but they don't have to go back. And you can bear with things, because there's other reassuring factors, i.e. the hemodynamics, as well as their blood work post-operatively, that means that you can hold tight. And that's why I've put down the 3 options are really: hold tight, transfuse, or re-explore. And that will be discussed with your senior when you come to make that decision. But what we'd like to hear from you is the assessment of how much is coming out, what the patients had, what operations they've had, and those are probably the 2 most important factors when you make a decision about whether you're going to re-explore a patient or not. Post-op, when you look at early, we've talked about the investigations. Bleeding. That should be bleeding rather than aortic. Apologies about that. So you do a chest X-ray to see how much, if there's a collection, is it all coming out in the drain? Is there a big collection as well? So if you've got a leaker in the bottle and you've got pleural collection as well, then this patient's bleeding in a way that's not going to be manageable without intervening. You're going to have to take them back to theatre. So chest X-ray is really helpful. Just get one if you're worried or concerned about a patient. It's a low-risk investigation. It's fairly available. And it should be done promptly if you're worried about things. It gives you a lot of information, but obviously examine the patient first and consider what's happening before you get ordered an investigation, almost second guessing it. The CT is really helpful. Sometimes we don't have the luxury of a CT because the patient's too unstable, so we just have to go back to theatre. And if the patient has some element of stability, then we may need to, or may want to get a CT to give us a bit more information to see whether there's any more detailed pleural collections or a source of the bleed, i.e. a blush of contrast coming out from a vessel. Then you have a rough idea of what you're expecting, as a cause for this. And then VATS, or open exploration, as the sort of definitive way of managing this. Infection. So again, it falls back to the high-risk patients that are likely to get infected. Are quite clear. You can see them a mile off. They're the ones that are on the steroids, they're the diabetics, they're the ones that they get 10, 15 infections a year because of their bronchitis, and you're still smoking. These are the sort of patients, they're very obese, they don't have much, they don't move around much, they've always sort of staying down with atelectatic lungs. These are going to be very high risk for infections. You can see them before they get them. And usually when we talk about infections, it's a pneumonia. That will be the most common reason to get an infection post-operatively. But it can also become an empyema or a pleural space infection as well. And things like a wound dehiscence is very rare in thoracic surgery. The blood supply is very good. We don't use the pump, the cardiopulmonary bypass pump usually. So we don't tend to see problems with wound dehiscence. They are rare. We can see them sometimes, but they're not that common, thankfully. And usually if there is going to be a big dehiscence of the wound, it will be the chest drain site, particularly after a patient that's had it for a while because of a prolonged air leak, for example. Or a patient that's already had an infected space and you're operating on them, they're obviously going to be very, very high risk because, sterilizing an infected pleural space is a very difficult thing. And so, as soon as somebody gets that, then it's something that's very tricky to shake off, and debatably if you can shake it off ever anyway. Assessment escalation. I think this is the final part of the talk, and it's supposed to talk about how you assess a patient, as an SHO and escalate. I think a lot of you know already the ABCD assessment, and I think following that is very helpful. It's a very helpful guide, not just for interviews and, when you're discussing things arbitrarily in a meeting or with your supervisor, but actually in reality, when you're systematic, when you're doing assessment, you follow everything, and you reassess if there's a problem. If you made an intervention, then you're not going to miss things, and you're going to be, when you document it like that, then nobody can fault you in your management because you followed the right acute protocols, and then always make and document a plan and then discuss it. So I think it's a good SHO is one that documents a plan very clearly. Even it doesn't matter if you're wrong. It really doesn't matter. You're not expected. You're not consultants. You're not expected to know the right answer at this stage. You just need to make a plan based on your assessment. So your reasonable plan, you've done your assessment, you've documented it, you make a plan, you write it in the notes, then you call your senior. And your senior is going to be your cardiothoracic reg, anesthetic ITU team if you need to, if the patient needs ventilation, if the patient needs a critical care bed, HDU bed, if that's managed by the ITU team, they need to speak to them to get that and get that assessment in early. You don't want to be speaking to the cardiothoracic reg who says maybe he's really busy at the moment, but he'll be coming up shortly to assess the patient. By the time he comes up, it's an hour. He reviews the patient and thinks, damn, this patient needs to go to ITU right now. You haven't even spoken to the ITU team. So just get things running in synchrony. Speak to everybody. There's no harm ever in discussing extra patients in a sort of critical care or very unwell patient scenario, because more people getting involved means that the patient's more likely to have the best outcome. I think that it's always tricky. The only time you can maybe get into trouble by discussing patients too much, if that ever exists, is if you discuss patient with one consultant who the patient's under, for example, and then you discuss it with another consultant who gives you a slightly different plan, and then you follow that one, and then you say, oh, I've discussed it with that patient, and then the consultant says to you, well, why have you discussed it with me? As long as you've got a very clear plan or a plan from a consultant, then just follow that. You don't have to discuss it again. And that's another obviously source for discussion when you're thinking or asking for advice. Consultant anaesthetist, they were involved in the patient, they know the anesthetic side of things, particularly in the recovery scenario. I can think of a couple of scenarios where the patient wasn't ventilating, for example, or wasn't behaving the right way in recovery. When we spoke to the consultant, we spoke to the anaesthetist, and they said, oh, this is likely to be, we haven't reversed their muscle racks, and probably that's what's going on, or the catheter and it was a tricky one. The patient was very obese, and so they may have cited it in the wrong way. So the consultant anaesthetist does have a role to play, as a person to escalate to. I think we maybe don't utilize that person as much. They're probably not as useful after the first operative day, because most of the anesthetic elements have worn off. But certainly somebody that you can use as a source. And then don't hesitate to pull the crash buzzer if you need to. If you need help, then you need it now. The best way to do it is, rather than having look for the phone, a free phone, or a free colleague that you can speak to, you just basically pull the buzzer and get everybody there, right there. The crash team, the intensivists from the local ITU that's going to be looking after the patient, and then you get them there. Maybe the most efficient way to save the patient. And a good SHO is one that discusses more and clarifies the plan. I think an SHO that thinks that they can do everything and thinks they're independent, that doesn't want to bother anyone, those are the ones that I worry about more than the ones that are always asking or not sure about things that want to clarify, because that way that person is safe. That person is wants to make sure that the right thing is happening to the patient. And I wouldn't hesitate to discuss, because you don't want to be taking the burden of the issues. If you don't discuss something, then the responsibility falls with you. Once you discuss it with somebody, it's somebody else's problem. And as an SHO, you're not a problem bearer. So you shouldn't be dealing with problems in yourself. You should be handing them over, getting a plan from somebody else, and then implementing it. Thank you very much. And taking